start off with Dr. Montford, who was recently promoted to an associate professor, so congratulations. From the Division of Nephrology. He actually did internal medicine house staff and nephrology fellowship right here with us and stayed, which we're very, very glad of. He basically is focused on improving care in individuals with chronic kidney disease or CKD. He's also really involved in advocacy for treatment of CKD for patients, which is really an important part of this life cycle of research from T0 to T4, really getting out there and advocating for the patients. He does that through the American Heart Association and the American Society of Nephrology. He's a basic science researcher, and he's been funded by the NIH and currently has a VA Merit Award. So his research involves study of mechanistic drivers of kidney fibrosis and AKI to CKD with a focus on innate immunity. So with that, I'll pass it on to Dr. Montford. Thank you for being with us.
So by way of introduction, I'm currently funded through the VA CDA program, the Career Development Award Program. For any trainees here or on Zoom, I would highly recommend thinking about putting in a Career Development Award. VA's CDA program is fantastic. The aim of our studies is actually not what I'm going to be talking about today, but the aim of our studies is to investigate the role of this thing called 15-lipoxygenase, which is an enzyme that's active in primarily alternatively activated macrophages, and we examine this in models of chronic kidney disease. And we've done our research. We've presented here at this conference before. It's been successful. It's been published. But, you know, some of the reviewers rightfully point out about the models. The models we have, preclinical models of CKD, are problematic in that the vast majority of them can create what looks like CKD in a kidney. Namely, it has inflammation, it has fibrosis, but it doesn't look like CKD outside the kidney, namely uremia, low glomerular filtration rate, renal failure. And so in concert with these studies, we looked at expanding using a second animal model. The prior one didn't have clinical CKD that we appreciated in humans. And we looked around, and like I say, it's really hard to model CKD, but one of the models used by many investigators increasingly is something called the aristolochic acid nephropathy model. Now, Aristolochia is a genus of plants that's used, that's worldwide. It's put in things like herbal remedies and teas. It has antioxidant properties, but it can create a really nasty disease, a human disease, that is characterized by tubular interstitial fibrosis, inflammation, even GU tract cancers. And it's been responsible for outbreaks of end-stage kidney disease in the developing world, such as in the Balkans in the 90s and currently in Asia since the early 2000s. And a lot of investigators use this because you can, it's commercially available as a purified toxin, and you can inject it in your animals in a rapid or slow fashion, and they reliably create CKD, not only within the kidney, but also the uremic manifestations of CKD that we appreciate in humans. So our animal model, this has taken a lot of trial and effort and failure, and we base this based on published data and our own successes and failures. We take, and this is predominantly done in black 6 mice, but we can do it in other mouse strains. We give these animals a vehicle solution, which in this case is saline, or this purified aristolochic acid, and you see the doses for male and female mice. We give it as intraperitoneal injections. We give it really slowly, but basically every other day for about 3 weeks, and then weekly for another 3 weeks. And we let the animals heal, and then after about 12 total weeks, we have our control group and then animals that clinically have CKD. And I wanted to go through the model. We've used it for the application of these other studies, but what I'm going to be talking about today is a little different, but this is the backbone of our studies. So one of the cool things about doing preclinical research is you can use investigational methods that are down the pipeline to maybe human use. So I'm going to talk a lot about something called transcutaneous GFR. So glomerular filtration rate, or GFR, is how we measure kidney function in people, and we estimate it using things like creatinine, cystatin C. But you can actually measure this using little devices in rodents. It's made by a company called Medibeacon in Germany. And you can see under the tape here, this animal's got it's like a little backpack with a battery plugged in. And what you do is you shave the animal, you stick it on the skin, and then you inject the animal with a fluorophore labeled inulin-like substance. Now, if you remember from physiology or medical school, inulin is a substance that is used to measure GFR, and it is rapidly cleared by glomerular filtration only. So you can measure it in the blood, and its clearance indicates if kidney function is normal or low. In this case, it's tagged to a fluorophore, and you can detect it through the capillaries in the skin. So you inject it in the animal. This graph on the right shows at baseline, there is none, and when you inject it, this device can detect it through the skin, and then it detects its decay as the substance is cleared through the kidneys. And you can actually see it in the cage and pee out this FITSI inulin substance. And the device basically makes a measurement every single second. And then the software the device comes with will look at the slope of the decline in GFR. And so this is what a normal kidney function looks like. This is a normal mouse. It has this peak and has a decline indicating the kidneys are doing what they should do. The clearance of the kidneys of the substance is rapid and it's well done. So in our CKD model, we can assess one animal individually, serially throughout the study. And so you're looking at about 10 animals in each group here. And we do baseline GFRs and then follow them out, and we do our injections like we talked about, and we follow them out up to 12 weeks. And you can see there's a divergence in their GFRs by as early as 3 weeks and 6 weeks and then 12 weeks. The GFR is measured in microliters per minute per 100 gram body weight. And in our animals with CKD, you can see the GFR is more than half of the control animals. So they have measurable loss of renal function that's chronic and stable. And then what we do in humans, we check things like blood urea nitrogen and creatinine, and those are both elevated, showing that the animals have azotemia, as you would appreciate in people with CKD. Within the kidneys, this is a PAS stain. On the left, this is normal control kidneys, and on the right, this is our CKD model. These are tubules. They're back to back. They have this little pink stuff in the middle. That's the brush border. And so this is normal on the left. And this is what our CKD mice look like. The tubules are dilated. There's a lot of inflammation. That's this little blue stuff. There's the leukocytes that come in. And then the glomeruli are preserved, so it's not a disease of the glomerulus. And then we can look at collagen and fibrosis using something called picker series red. And picker series red is a stain that gets in and impregnates in the kidney, and it binds to collagen. And then collagen, you can polarize the image, and you can get a clean signal of how much collagen is in the kidney. So this is fibrosis on polarized picker series red images. You see a little around the vessel in a control kidney, and then a lot in the interstitium of these animals. So this is what we see in human CKD. We see a lot of fibrosis. And then to drive that point home, if you look at the animals' kidney weights divided by their body weights, because they lose some weight, you appreciate renal atrophy. And that's what you see in people with CKD. And then looking outside the kidney, what we see in human CKD is a loss of weight. You get sarcopenia, anorexia, and you see that in these animals. And then also this is measured whole blood hemoglobin. These animals are significantly anemic. So this is to convince you that these animals have a form of CKD that looks, pretty consistent with what humans have with CKD. And so we created this model, we applied it to our studies, and as we got going, life happens, and COVID disrupted everybody's life, and in research, it's forced us to a lot of times pivot our priorities, gets us to think about, what are we doing on this earth? And for our patients, I'm really focused on CKD, and I have a large contingent of dialysis patients. And infection is an enormous burden on people with CKD, and I never really thought about it that much, at least applied to my research studies, until COVID came. And as you may be aware, COVID has been devastating on dialysis populations and in patients with CKD. So it got me thinking. I had some time to think. We've got a pretty good model of CKD. It's better than a lot of models. It's a clinically stable model. What if we induced infection in this model? And this is not something that was originally in my career development studies, but again, life forces you to pivot sometimes. And infection in CKD is a leading cause of death and disability in CKD. It's probably the second most common cause of death in individuals with CKD, including dialysis, next to cardiovascular disease. And the proposed mechanisms are, there's adaptive immune defects, there's innate immune defects, there's altered gut microbiome, uremic solute retentions. A lot of this is based on association studies, observational studies in humans, and ex vivo stimulation of, for instance, neutrophils in people with CKD. But if you ask experts in this field of infection in CKD, and I have, why do people with CKD get infected, and when they get infected, die with higher rates than people without CKD? And the answer is usually, well, everything is wrong. Everything is just wrong. And this is kind of an unsatisfying conclusion. And I think a lot of the problem is that infection is hard enough to model in a preclinical setting. It's even doubly harder to do in, say, a host that's immunocompromised. And I'm not an infectious disease doctor. There's lots of ways to model acute infection. My simplistic understanding is you can inject substances like lipopolysaccharide or zymosin, a sterile irritant, into the peritoneum, and they get something that looks like acute infection. You can inject a purified virus or bacteria into an animal and give an infection. The gold standard considered by many is cecal ligation and puncture, where you give an animal a laparotomy, you anesthesia a laparotomy, you partially tie off its cecum, and then you puncture the cecum, and then you sew the animal back up. And I looked throughout the literature. Has anybody ever actually tried and been crazy enough to give an animal with existing kidney disease infection to study its immune system? There's one group that did cecal ligation and puncture, and all of its CKD mice died. So I decided, well, okay, this may be good. So we created our controls and our CKD mice, and we did cecal ligation and puncture, and we faithfully reproduced what these other investigators found, which was all our animals died. And many of them died within hours. And so this was not necessarily the cecal ligation and puncture, this was the anesthesia and the laparotomy. So this is a very morbid thing to do. And we thought it ill-suited for our designs. And I credit, I reached out to a guy I knew in infectious disease, James Colbert, I did residency with, and he has a model that, there's a newer model of examining peritonitis, only doing it not using a sterile irritant, but doing it using actually live bacteria. And it turned me on to something called the cecal slurry model of acute peritoneal infection. And this has been documented over the past 10 years or so. James uses a slightly different model, but essentially what this is you take animals, they're donor animals, open them up, take the cecal contents out, sort of filter them down, create a solution that you stabilize, and then inject in recipient animals. And the interesting thing about this model, it looks kind of like lipopolysaccharide. If you give an animal IP LPS, they get hypothermia, they can die with high doses. You can create a dose-dependent degree of sepsis. And this is a study looking at different doses of cecal slurry and the effects of age. And you get a dose-dependent increase in mortality in these animals. But unlike, say, something like lipopolysaccharide, these animals get bacteremia. They get measurable bacteremia, which is definitely an advantage. So I'll go through this, how we do this, and I knew you were going to be eating lunch today, so I didn't create pictures. I just created cute cartoons to show you. So, the way we do this is we generate our control in our CKD mice. So we go through 84 days of this. We then isolate and dissect, so we have to euthanize these animals. We isolate and dissect the cecum and their contents. We put it in a PBS solution, a phosphate buffered saline with glycerol. Now, glycerol is needed to stabilize the bacteria for when we later freeze them to keep them alive. We perform a serial filtration through these various size filters, and we combine animal groups. We combine a number of animals, like 10 animals per group. So we do 10 CKD animals and create this, or 10 control animals and create this. And we put it into a big beaker, we continuously stir it, we partition it into cryovials, and then freeze it at negative 80 degrees, and we use it within 6 weeks. The published data using this exact method indicates that bacteria can be thawed and injected later, which is what we do. and they're viable even beyond 6 months. So we do this within 6 weeks. So the breakdown of our studies is up to the top right. We generate our donors, we isolate group matched vesicle slurry separately. We create our control and our CKD mice, and then we either give them a sham solution, which is that PBS glycerol, or we give them a low dose of vesicle slurry or a high dose. Exact details of the dosing strategy and what's low and what's high, I won't bore you with, but a lower dose and a higher dose. And then we would give these groups, all three, three separate groups. We would follow these animals out for either 24 hours or a separate group at 72 hours. And we would clinically monitor them in terms of survival, degree of sepsis severity, looking at things like temperatures and sepsis scores. And then upon collection, we would look at flow-sorted blood leukocyte populations and inflammatory markers and things like that. For two purposes, really. Can we do this? Is this going to turn out like our cecal ligation and puncture studies where all our animals died? And can we get some kind of clue? And my focus is on innate immunity in general. So is there an innate immune defect I can uncover with this? And then could this be a launching pad for future investigation? So in our groups, we found that most all the animals actually tolerated this at least up to 72 hours quite well. However, in our CKD animals receiving this higher dose of cecal slurry, we lost nearly half of them by 72 hours, starting at about 36 hours. In terms of looking at the sepsis severity, I mentioned we have different ways of looking at this. This is the objective way. We check rectal temperatures on them, and even within 1 hour, and this happens in control mice, you get acute hypothermia, and then you get some recovery of the temperatures. But even as early as 1 hour after infecting these animals, and this is the low dose on the left and the high dose on the right, you get a divergence in the CKD animals. They have worse hypothermia. And then particularly in the surviving mice out to 72 hours, they take longer to recover. So they're sicker acutely and they take longer to recover. Now, the GFRs I mentioned before, and again, the cool thing about that is you can monitor this in animals that are live. Now, our control animals have a GFR, I told you, around 1,000. Let's say that's normal. Our CKD animals are down around 200 to 300. They're pretty low. And so I'm not showing you the absolute GFR numbers. I'm actually showing you the change in the GFR. So what we do is we take every animal, we take a baseline right after we generate either the control animal or the state of CKD. So we get a baseline GFR on them. Then we infect them, and then when we euthanize them at 24 or 72 hours, we do a second GFR. And so what you're looking at is the final GFR after sepsis, as a percent change versus the baseline, because that's a more honest way to assess it. And on the left, you can see that there's not much change in GFR in the control groups, on the low dose cecal slurry, but on the high dose, maybe there's a non-statistically significant trend towards lower GFR at 24 hours. The same kind of thing, again, you get a dose, we're recapitulating what others have found with this model. You get a dose-dependent increase in sepsis severity. And it's not statistically significant, but there is a more of a GFR loss in the animals with existing kidney disease. So on the left, what you're really seeing is new septic acute kidney injury in animals with normal kidneys. And on the right, what you're seeing is septic acute kidney injury on top of existing CKD. This is complicated, but this is actually something we see all the time in the ICU. CKD patients are highly predisposed to new acute kidney injury events. So we thought this was kind of interesting, and it's another method to see the degree of sepsis severity. And we looked at plasma cytokines. So I'm showing you TNF alpha, CXCL1, IL-6, and IL-10, and there's a number of others, but acute inflammatory markers go up. They seem to peak at 24 hours and then sort of go down near controls by 72 hours. And then finally, there's a lot of bars here, but we did flow, and I'm not showing you the full picture in the interest of time, but marching this from sort of the left to the right, our sham animals have a certain number of peripheral leukocytes. If you give them cecal slurry within 24 hours, they develop acute leukopenia, and then they reconstitute by 72 hours their peripheral counts. And there's a sort of a dose-dependent, sort of impaired reconstitution. Not much difference. We were kind of surprised by this in the CKD mice in terms of the peripheral leukocytes. again, I don't have time, but there are changes in neutrophil and macrophage populations that are kind of subtly different in our CKD mice. So we said, this is really interesting. We're thinking about publishing this. But, it got us to thinking, there's actually two phases to this model. And there's not as much data on AKI, acute kidney injury and infection, but there is an emerging amount of data that death from infection is the leading cause. It's the leading cause of death after AKI is infection, and there's really not that much literature about it. And so I credit Sarah Favell, who does a lot of AKI research, to sort of leverage this model and maybe examine it at a different time point, namely acutely. And so we did this kind of a second time around. We gave the animals the same kind of strategy, only we euthanized them much earlier and during this AKI phase. Now, their GFRs by day 21 are around 500-600. To put that in context, in the CKD group, they're about 200 to 300. So the renal failure is there. It's not as bad. The BUN and creatinine, the BUN is not elevated. The creatinine is a little elevated, not as bad as in the CKD mice. I'm going to breeze through the histologic findings. Long story short, there's no fibrosis. There's just tubular injury. The animals develop renal edema, which happens in humans with acute kidney injury, not fibrosis and atrophy. And ultimately, they do develop a little bit of weight loss and some minor degrees and anemia. So the clinical picture I'm painting is that this is renal failure. It's acute. It's mild. And the extrarenal manifestations of this form compared to the CKD are less severe. And so we wanted to use this as a complementary model to our CKD studies, thinking we would find, well, if our CKD mice are pretty frail, these mice are less frail, they will have less sepsis severity than our CKD mice. And so we went about the same set of studies. We created our donors, injected this, isolated the slurry, injected them into our recipients. We found the exact opposite. We found that these mice did not tolerate this at all. All the animals getting the high doses died within 24 hours. Some of the animals getting the low doses died within 24 hours. The delta GFRs, like we talked about, but in the high dose group, all of these animals, even though they started with the higher GFR, their GFRs went to 0 with high doses of cecal slurry. And basically, we think they're in septic shock. They're rigoring, doing quite terrible. I didn't show you bacteremia, that you could plate out, bacterial cultures. And in these AKI mice, they have a high degree of bacteremia. And for context on their cytokines, their cytokines go absolutely ballistic. So this is a look at TNF alpha in our CKD mice, and you might be fooled. It looks the same, but if you look at the y-axis, this is about a 10-fold increase in TNF alpha versus our CKD mice, even though they have better renal function and look a little more robust. And then the total leukocytes, they have much more leukopenia, and they don't reconstitute their peripheral counts like the control mice and like the CKD mice do. So there's a lot more data. I don't have time to go into it. In the AKI mice, there's significant defects in neutrophils and M1 and M2 macrophage activation. We've just sort of started unraveling this. But in summary, what we've shown is we can model acute intraperitoneal live bacterial infection using this method applied to rodents with pre-existing AKI and CKD. And this kind of two-step method can really potentially improve the ability to model something which we see every day in the ICU, or we see every day on the floors. And this is the first time I think anybody's really been able to demonstrate something like this in a preclinical model. So we're pretty excited about it. And that our AKI mice have much worse clinical and biochemical sepsis severity than our CKD mice, despite the fact that they're actually younger. And again, age makes this model worse. And they have higher baseline GFR and hemoglobins. And our hypothesis is that AKI more than CKD predisposes to a really early aggravated inflammatory response that appears to be insufficient to clear bacterial infection. And it might be due to a defect in resident or recruited neutrophils and macrophages. And we have some ongoing studies to investigate, and kind of run out of time. I just want to say thank you to Deanna, who's my research assistant, who's done a lot of these studies. She just had a baby. She's on maternity leave. Jeremy, who's helped me out with flow at the VA. James, Dan Frank, who's working on a 16S bacterial DNA analysis of our slurries. Sarah, Seth, Sean Coleman, who helped mentor me, this guy Hiroshi Saito, who helped develop the original model, and I collaborated with everybody in the renal division and at the VA. I'd be happy to take any questions. I know that was a lot, so
Great presentation, thank you.
thank you.
Look, can you tell, like, from the high to the lower dose whether the acute kidney injury is mediated, or do the animals die because of immune dysfunction, or is it just like severe pre-renal azotemia because, or there, like in sepsis, we know there's renal artery vasoconstriction and reduced renal blood flow.
Yeah, the answer to that, I mean, in humans with AKI who get sepsis or CKD who get sepsis, they don't die from renal failure so much. If they do, it takes days, not weeks. And so the fact that these animals GFR goes to 0, and we assessed at 24 hours. It may be that the GFR is different at 4 hours or 6 hours. We didn't check. But the fact that they're starting with GFRs, let's say the AKI animals at 500 to 600, and they go to 0, they're not dying of renal failure. I mean, if you make an animal anuric and remove its kidneys, it won't die for a week. So these animals are dying far too fast, and they're dying of septic shock, and it's pretty obvious. They're rigoring. We haven't measured their blood pressure. They're hypothermic, and again, we're growing bacteria from their blood like gangbusters. So we think it's all just overwhelming sepsis, not renal failure. That's just more of a kind of a severity of sepsis biomarker we're using.
Can I ask a question about your inflammation responses in both the AKI and the CKD mice? You showed quite a dramatic increase in pro-inflammatory markers, but you also showed quite a dramatic increase in IL-10, which is anti-inflammatory.
I'm glad you picked that up.
And can you tell us a little bit more about that?
So, this is something that's seen in severe sepsis, and it's also been seen in AKI outside of sepsis. You seem to get with severe AKI or severe sepsis, you seem to get a simultaneous acute, hyperacute, as well as counter-regulatory acute dysfunction that occurs in parallel. And so with the severity of injury, it seems like, the IL-10 goes bonkers, but this has been shown in people with AKI, and I'm pretty sure this has been shown in people with severe sepsis is to be just a hallmark of horrendous sepsis. These cytokines, even the anti-inflammatory ones, go bonkers acutely. And so, yeah, we think it's a simultaneous dysfunction of both. And to tease that out, we propose some studies, in more mild infection looking later on. If you really want to look at counter-regulatory acute versus hyperacute, you really got to examine the animals later on with subsequent insults. That's a good question.
Any more questions? If not, thank you very much.
Thank you.